So this program has not received any financial or in-kind support. It's being offered by the Alberta Medical Association. Next slide, please, Norma. So this one just states the bias or lack of bias. So fortunately, there is no bias in what's being presented. Next slide, please. And this is Norma's disclosure. Next slide, please.
I'll disclose that I have no relationships with financial sponsors other than my employer, who is the Alberta Medical Association.
Thank you. So I'd now like to welcome Norma Shipley. Norma has worked for each of the 3 major healthcare organizations in Alberta, the Alberta Medical Association, the Alberta Health, and Alberta Health Services. She has spent most of her career with the AMA and worked in a variety of positions, including manager of AMA's fee schedule. She has an interest in alternative physician compensation plans prompted models prompted her to take an opportunity with the ARP program office, following which another opportunity led to a role with AHS Medical Affairs with responsibility for provincial standards and systems for physician workforce planning, recruitment, and appointment and privileging. An opportunity at the AMA as fees consultant on the AMA's health economics team led to her return to the AMA in late 2018. Norma brings a broad range of expertise to her work, serving members as an expert in the Alberta Schedule of Medical Benefits and fee-for-service billing. She offers education and training sessions to residents, physicians, and physician office staff on the Schedule of Medical Benefits and WC billing. She also serves as an AMA representative on the AMA WCB Advisory Committee. So, knowing that we have lots to get to this evening, I'm going to pass it over to Norma. And please remember to enter your questions, and we will try and answer as many as we can. Thank you.
Thanks, Mary Lee, and thanks everyone for coming out tonight on such a lovely summer evening to talk about schedule and fee schedule issues. I'm going to divide tonight's presentation into 3 key areas. First, we'll talk about the virtual codes that Alberta Health has introduced to account for your patient services during the pandemic while everyone is perhaps not wanting to deliver services in person, or your patients don't feel safe coming into your office. Then we'll focus on the March 31 schedule changes, and then we'll have a much broader presentation that is more typically about office-based practice and billing for your services, both visits and procedures there. After each one of those sections, excuse me, we will pause for some questions. And while we're doing that, we will have Jocelyn and Mary Lee theming and grouping the questions. But again, it really helps if you use that little thumbs up button in the Q&A chat box so that you can upvote questions, so we don't have a lot of duplication. Makes it a lot easier for everyone to be really focused. So let's get started. So one of the things that I always like to talk about is the schedule of medical benefits and its philosophy. And so we'll talk a little bit about what is and isn't insured, why isn't it paid. We'll talk about the specific components because they comprise the whole schedule, and they all have an important part in determining payment, when things are paid, and how much. We'll talk about how do you stay up to date, when and where are the changes published, and we'll really focus in on those, as I said, virtual codes and March 31 changes. We'll talk about monitoring, which in my view has 2 components. From your perspective, you want to make sure that you know what's being billed in your name, and you want to make sure that you're optimizing your billings while you're staying within the schedule rules and requirements. At the same time, you need to know a little bit about Alberta Health Review, how they audit, and we'll talk a little bit about that in the later part of the presentation. So understanding the schedule pays for your direct in-person services to patients, except for technical services, and for family medicine, those can be some of the more broad lung function testing and so on. The delegated services, those are very specific services for family medicine. Physician to physician or other health provider communication, and then specific phone or other telecommunications contact with patients, and that includes the virtual codes. So it's really important to understand when you can use those telecommunication services to provide your contact with the patient, and when you can't. Another thing it's always important to understand is, how do you determine the correct health service code? Your EMR and your billing software will have a very brief description of your individual service codes, but it's important to remember that you need to read the full description, the modifiers, and the rules to really understand when and how you can use those codes. And so where do you get those? You can get them from the AMA's Billing Corner. Alberta Health Bulletins can provide more detail around that. The AMA's Fee Navigator pulls all the pieces of the schedule together. And so, for example, if you go to the Fee Navigator and look up Health Service Code 0304A, it will give you the code, its full description, any notes that are associated with it, the rules that are associated with it, and then it will also present to you all of the payment rates for the various specialties. It also will tell you what modifiers are available for each code. If you're interested in some really dry reading, you can go to the Alberta Health Professionals website and you can download the parts of the schedule. If you're having some insomnia, that's a great way to put yourself to sleep because it's very detailed, very legal. But it's important, if you want to see the schedule as it is written, that's the place to go. And then the other thing I always like to remind physicians is, it doesn't matter how great your billing team is. I'm sure a lot of you have really great billing team members. They've been with you for a long time, or they've become highly recommended. And that's a very important part of your billing. But you, the physician, are in the room with the patient. You know the service that you provided. And so it's really important that you're deciding what fee code, how many of a particular fee code, for example, you want to bill, and that you are driving that billing choice. Let's talk a bit about the virtual care codes. So Alberta Health has introduced 7 new billing codes for virtual services during the pandemic. They're time limited at this point to the duration of the pandemic as declared by Dr. Hinshaw. They're not subject, and this is very important, they're not subject to the daily cap on office visit services that for a number of communities will exist March 31 forward. They are very similar to the existing codes. So for example, those of you who are familiar with 0303A will see that there's a lot of similarity with 0303CB, but there are some differences. One of those key differences is that they must be initiated by the patient. So how can that happen? That could be the patient calling for an appointment. It could be a referral for a consultation. It could be part of your ongoing follow-up care and treatment for a particular illness and condition. But you, the physician, may not solicit that visit by cold calling. That doesn't mean that panel management isn't okay. So for example, if there is a decision to contact vulnerable members of your patient panel, those who are frail, elderly, living on their own, for example, there was a decision for you to contact that group or have members of your team contact that group to see if they wanted to have an appointment with you, that is perfectly permissible. So some of the differences are to do with time and other requirements. The only time that you can include in the time requirements for these service codes is your direct physician-patient contact time. No other time can be included, so unlike your 0303A with the CMGP, you can't include the time that you might spend charting, reviewing patient records beforehand, writing your referral letter after the contact, and so on. Your 0303AD, that is the $20 code, is for asynchronous contact. So for example, secure email, or for a visit, direct patient and physician contact that is less than 10 minutes. All of the other codes must be at least 10 minutes, and the mental health services codes for family medicine have a 15-minute unit requirement. We'll talk about that in a little while. Part of your detailed patient record, and Alberta Health has said this very clearly in their bulletins and in the descriptions of the code, is that you must record your start and stop time of the direct physician-patient contact. I've had physicians say, well, I'm going to use my EMR time, And if you're only keeping your EMR open for the duration of your direct physician-patient contact, and you're very confident that that information would be readily available if there ever was a question from Alberta Health, that's okay. But really, my advice to you would be, in your record of that contact, just note the start time and the stop time of your call or your video conference with the patient, and then you can be very confident that that information is easily available. Again, have to be patient driven. So, there's an appointment request from the patient. It is part of their ongoing course of care. And remember too that these codes are not eligible for the premiums and modifiers that your other health service codes are eligible for. So no CMGP, no CMX C30, and they're also not available for the business cost and rural remote northern program payments. Some of the other requirements and limitations are you may only claim one virtual care or in-person service on the same day. You can't claim any other visit services, and they are not providing general information about COVID-19. There has to be a companion request or an additional issue that the patient wishes to discuss with you. For the 0301 AD, you can have email exchange with the patient or a phone or video conference that's less than 10 minutes. It includes the prescription renewal or a new prescription, and that's why we have been saying that an 0301 NM may not be claimed in addition. We know that Steve Buick, the noted billing expert from the minister's office, has said you can bill the 0301 NM in addition, but we have not yet had clarification from the staff within Alberta Health that are responsible for the fee schedule that, in their view, that's okay. For the 0303 CV, that's your virtual 0303A. That needs to have 10 or more minutes direct contact by phone or video with the patient. And then, that's for a limited assessment of the problem, advice to the patient, creating the patient record. And that, again, has to include your start and stop time. I'm going to skip over the 0303 FV, so I apologize for that. That's for specialists. The 0308 CV for any of you who have a consultative practice. So you're bringing in people who have been referred to you by a colleague for example, low-risk obstetrics. This is 10 or more minutes of direct contact by phone or video. Needs to be a comprehensive assessment, history, and a detailed record, again, with start and stop times. And again, not claimable on the same day as another virtual or in-person visit, and has to be initiated by the consultation request. We still have those requirements for consultation, so referral from another physician or the other defined health professionals, and the return of the consultation letter. For those of you who are doing mental health services, and this is really important to note, there are two specific codes for mental health services. One is the 08.19 CW. This would be used for family physicians who are using the GP skill code in their claims. That service needs to meet two criteria. The patient must have an established psychiatric diagnosis, and that diagnosis must have occurred at a previous contact with the patient, so a previous visit, a previous virtual care visit. The other thing is that you must meet that full 15-minute requirement as a family physician. The requirements for generalists in mental health who work in community mental health clinics are different. They are more like psychiatry, but for family medicine, Alberta Health has imposed this full 15-minute requirement. Again, this is only for the direct physician-patient time. You need to have that detailed record and not claimable with other in-person visits or virtual services on the same day. For virtual care, we just last Friday confirmed a set of principles with Alberta Health. So overall, the billing rules haven't changed and they follow the established rules for in-person visits. You can only include physician to patient direct interaction, and the patient-initiated visit definition can include patient-initiated appointments, clinically necessary follow-up of an ongoing condition, or a previously initiated treatment plan. The direct patient contact resulting from management activities can also be a driver of this, and that is intended to ensure that chronic disease and high needs patients receive appropriate care. So the example there is, socioeconomically disadvantaged patients with mental health issues. Another is a frail elderly person who might be socially isolated. The other piece where Alberta Health has been agreeable to allowing contact that is initiated by the physician is contact following referral by an AHS screening program, and that includes COVID-19 screening. So if you receive a report from an AHS screening program that a patient has tested positive, you can initiate that follow-up contact with them and be confident in making that claim to Alberta Health that you're meeting that requirement for not a physician-initiated contact. So some examples of this, we talked about the socially isolated or frail elderly person. We talked about long-term care patients. I've seen a question in the Q&A about those. We'll talk about that in a second. Chronic disease, including patients with significant mental health issues. Maybe your complex pediatric patients need ongoing follow-up. And your long-term care patients, there's recently been some discussion between AHS, the AMA, and Alberta Health about how do you make sure that your long-term care patients are being appropriately cared for. And in this case, there is agreement that physicians can initiate that contact with their long-term care patients to ensure that that longitudinal care for that frail group and that high needs group is being met. So PCN or your hospital clinic staff or your office staff may initiate the call to that patient. And that could occur in the area of panel management. It could occur in the area of having staff contact a number of your patients to indicate that your clinic is open and you are available for virtual visits. All of that can be claimed by the physician. If the end result is the patient wishes to speak to you, you can then claim for your direct time, but you can't claim for the time that your staff may have taken to initiate that call, talk to the patient about what services are available, and so on. The other area where there's been agreement that that physicians can initiate contact is where you've had a request from your hospital or your zone medical leaders to contact your elderly and high-risk patients who are at risk in the event of COVID-19, if they should contract it in the future or if they currently have that. And the goal of that conversation would be to talk about goals of care for that patient. So I see a question here about advocating for changes to other codes and billing codes for palliative care. So I will talk about that a little bit right now as part of the questions. It is important that we hear from you about issues and concerns you're having, excuse me, about the billing codes, the virtual codes, the changes to March 31 and so on. That's one of the key drivers of our discussions with Alberta Health, but the other thing is physician advocacy on social media. We've seen the benefit and the strength of that in the changes that were withdrawn over the weekend by the minister in the area of rural remote northern and the area of the Z codes in hospital facilities. So a two-pronged approach, I think, is very beneficial. And it's really important, though, that we hear from you so that when you're advocating on social media, at the same time, we're advocating with the staff level people at Alberta Health so that we are making sure that as these things are being put forward in social media, we're having a discussion at the staff level about how to rationally and appropriately make those changes. Because over the weekend, we had a really good demonstration of what can happen when a government organization without a close connection to the care provision and the needs there starts making policy and making changes without the input of people who understand the system. Okay, I'm just going to check and see what's going on in our documents about changes and questions. So calling family every day is on your hospital shifts. Can I get you, Dr. Bayer, to hold that question until we get to the section of the presentation where we're talking about questions about indirect contact with patients' families and so on. And we will make sure that, that we talk about that when we get there, okay? So some of the things, the old virtual codes like pediatric mental health when you talk to and calling family of patients, that's another question from Dr. Bayer. We'll get to those when we talk about more in the regular scheduled issues. 0301 AD doesn't mention email. Dr. Burgess has asked, are we sure it's okay? And yes, we are. Alberta Health has been clear that it can be used for either phone or video consultation or email. It doesn't have that specific requirement for direct physician-patient contact. So I'm just going to pop over for a second, and I'm going to move my one computer because I'm not able to see the Google Doc. So some of the themed questions coming out, 0301S, we'll talk about in the team conference and other part when we're talking about the more the more specific ongoing schedule codes. Virtual care codes in DAL and long-term care. If you're using it for virtual rounds with patients, it can be a continuation of chronic care, as we've talked about earlier. So part of that panel management activities. And one of the things that it's important to make sure that you're having in place there is direct physician contact with that patient. There is going to be some communication coming out from AHS about the specifics of that requirement, but I think it's important for us to wait for AHS to send that out because that's been a little bit of an on the side activity between AHS and Alberta Health, and I want to make sure that we don't have a late minute surprise and give advice before they finalize their issue. I've had a question from Dr. Lefebvre about texting, which I assume is related to 0301 AD. And as long as you're using secure texting, so texting your patient from your iPhone using, say, iPhone texting support probably isn't going to meet those security requirements. So it's important to make sure that you're meeting those security requirements that are laid out by the college and the Office of the Information and Privacy Commissioner. If you meet with a patient about their child without the child present, how do you bill for that? Under the virtual care codes, that probably would require child's presence in order to bill for one of the virtual care codes. There are codes in the that we'll talk about a bit later in the presentation that can be used when you are talking to a patient or their family in the community. And I would recommend that if you're talking with a parent about the child not present, that you use one of those patient in the community codes that we'll talk about in a little while. Regarding ongoing patient course of care, if you're calling them to talk about lab results, and follow up, and that would have been a normal part of your practice. If you were seeing them in person, definitely then you can use the comprehensive care the virtual care codes. As long as that requirement of 10 minutes is being met, you can use the 0303 CV for that. That's not considered patient initiated because you are actually following up on a course of care that you started when you made the original diagnosis, and you are then taking action based on results of testing that you have received since. I'm going to, unless there are other questions regarding the virtual care codes, I'm going to go on and talk about the March 31 changes. So Alberta Health has imposed those changes on March 31. It's updated some on April 23rd, so those are the Z codes primarily. The AMA has not been involved in the initial development or determination of the exceptions published on April 20th. Overall, we don't support the changes that are being made except for the return to the full rate for the Z codes. The April 20th exceptions are a good first step, but overall review and collaboration is really required to ensure that we're taking a fair and equitable approach to these changes. And the other thing I would just remind you is these changes, because they were made without the AMA's input, may have errors or inconsistencies in their application, and the AMA has had zero control over what's happening with those codes. And so we have not had the usual level of input into that, and that is really the foundational reason for some of those errors and inconsistencies. So some of the things that are changing, all of you will know that submission deadlines have changed from 180 days to 90 days. So what does this mean? For services up to and including March 30th, you can submit those claims up to 180 days after that date with, good heavens, with the, sorry everyone, I apologize for this. You can submit those up to and including 90 days. We have been able to, in some cases, have Alberta Health grant specific exceptions to physicians and clinics who have a very high number of outstanding days over the 90-day period. If you have, say, 200 or more of these claims outstanding, please send an email to billingadvice@albertadoctors.org, and we will help you negotiate an agreement with Alberta Health. They will give you a specific period within which you can submit those claims without text. If you have already submitted those claims, though, they will be in that manual assessment queue. And if you resubmit them, you will get a notification from Alberta Health that they are duplicate claims. So I think that is not going to be in your interest. So at times, the minister may give special permission to submit claims outside of that claimed period, which is 90 days now, but that's very rare. You need to have had a disaster, a fire, a flood, an employee has stolen records, and there is really little or no flexibility for situations outside of that. Alberta Health is very stuck on that's the requirement. So my advice to you is be paying attention to your claims. If you are claiming outside of that, 30-day period, you need to start thinking about how am I going to get those claims in and get them resolved before the 90-day period sets in. So good faith claims. I know this is a significant issue for a number of you. The good faith claims are no longer payable March 31 forward. If you have services, though, March 30th and before that you haven't yet submitted to Alberta Health for payment, you'll need to submit them with text. They'll go into that manual assessment queue, and then you need to make sure that you're following up on those so they don't become stale dated. Now, though, when you provide services to a patient, including in hospitals, you, the physician, are responsible for verifying patient eligibility. So you need to be checking Netcare to see, does that patient have Alberta healthcare insurance at that time, or have they presented a valid health insurance card from another province? If they cannot, and I know this is not a workable solution in many emergency situations, but Alberta Health has said you may direct the patient to a registry office to sign up or renew their insurance, after which coverage may be retroactive depending on when they became residents of Alberta or on other eligibility criteria. In the meantime, you can bill the patient for that service, and then later, if they come back to your office with evidence of their health insurance being established, you can make a pay-to-patient claim to Alberta Health. They will reimburse the patient. You then have been paid, and you don't need to worry about trying to then seek payment. If your office staff are having questions about making that pay-to-patient claim, you can refer them to the Physician Resource Guide or to the AMA for some assistance in how to make that claim. Your comprehensive visit has a new rule that describes some care planning that must occur in the context of that visit in order for your O304A to be claimed. This is really quite a significant change and wasn't communicated by Alberta Health before they published the schedule on March 31. So this took everybody by surprise. The rule says that there must be, to claim an O304A, discussion of a care plan related to the patient's condition, and patient advice, including the care plan discussion, must be documented in the record. But the care plan, unlike the O304J, does not have to be formally signed by the patient. We've asked Alberta Health for a definition of their care plan. They said it must be specific to the patient, document findings and the plan for the patient, and again, has to be recorded in the patient's record. We haven't had a lot more specific about that. We hope that we will be able to find the information and get them to be a little bit more specific in this. We will make sure that that information gets published once we've received the information. So if you have questions about claims older than 90 days, please use the resource guide or the resource page at the end of this presentation, which will be posted, and email that to billingadvice@albertadoctors.ca, or you can call the AMA main number 780-482-2626 and be directed to the appropriate person. That will be either me or one of my colleagues on the physician payments team, and we can help you out with that. Just going to check for this. So this presentation apparently has some rules in it that are running away. One of the things for physicians to keep in mind when you work in one of the 7 urban centers or a couple of the bedroom communities, we'll talk about which communities this applies to in a minute, is that there is a new cap on the number of visits Alberta Health will pay you at 100% starting March 31. The virtual care codes, though, let's be clear, are not included in this cap, but any other V category service is included. So that means in-person visits, phone calls to patients, team and family conferences, any communication by phone or telehealth with other physicians or health professionals, community agencies, is included in this V category service grouping. It also includes services that you would provide from your home or at a patient's home or in a non-regulated facility, and that's assisted living, designated assisted living, and so on. So this is very specific and targeted, and it's important that you be considering how you're going to bill and manage these patient volumes, because you will want to make sure, for example, that if on a particular day you are going to be over the 50B category services group, that you're billing your higher value services for that group this week, and then your lower value services, phone calls and so on, next week, so that if you're taking that decrease of 50% for visits 151 through 65, you're taking that decrease on the lower value services. And why is it important to do that? Because when Alberta Health pays your claims, they do it in numerical order. So they will start with 0301 and then go to 0302, 0303, 0304. So you will want to take that decrease on the higher value, or sorry, on the lower value services, not on your higher value services. Where does this apply? It applies in Edmonton, Sherwood Park, St. Albert, Devon, Stony Plain, Leduc, Fort McMurray and Grand Prairie, and then Red Deer, Calgary and Airdrie, Medicine Hat and Lethbridge. So if you're practicing in one of those facilities, this is a time when you need to, once you start seeing patients in person again, that you need to make very certain that you're keeping track of how many V category services you've provided in a day, and then how many lower value services you have. Make sure that you're balancing out that claim frequency. There are some codes that have been deleted March 31, and so those are the comprehensive care plan. That one is delisted, now part of 0304A requirements. And the 0305H driver's medical for 74.5 and older has now been de-insured. So that means that it is no longer an insured service. So when you have your patients come in, you will need to bill them for both the visit and the form completion. And you may not claim the visit to Alberta Health unless there is a very significant other issue that you're dealing with. For the most part, though, it is much better practice and much cleaner if you have the visit and form completion at one patient contact. The AMA Guide to Billing for Uninsured Services can help you with setting the appropriate rate. And I would just caution you, in the bulletin that Alberta Health published, they made reference to physicians only claiming the currently listed rate in the schedule for those uninsured drivers' medicals. You are not bound by that. Once Alberta Health de-insures an issue, then they can no longer set the rates for that. So there are new codes, and I've seen a few questions in the Q&A about the new Z codes. So a bit of confusion happened around those over the weekend, but here's the scoop. The Z codes will still be in existence. So when you provide a service that is an 0303A, an 04A, or any of the other codes listed on the next couple of pages in a public facility, so that means you're in an AHS facility or a Covenant Health facility, you're in a long-term care operated or contracted by either of those organizations, you're working in a community mental health clinic or one of the public hospitals to care for mental health patients, you must use those Z codes. As of April 20th, after the Minister's News Conference, Alberta Health indicated that they will pay those codes at the same rate as the companion code. So for example, 0303AZ will now pay the same rate as 0303A. In rural sites, that will be an ongoing convention, but in urban sites, the rates will continue to be paid at the same rate as their companion code until October 1, when it's anticipated that more work will have been done by AHS and Alberta Health and the AMA to identify where in AHS facilities physicians have private offices, what those facility numbers are, and then how they can identify those properly so that services in those clinics are not affected by the Z code reduction, should it continue. So that exception would be for facilities that are in an AHS facility where there's a separate facility number and the physician is paying an overhead amount to AHS. For out-of-office visits, what public health facilities are included in that Z code requirement? So those are hospitals, active treatment centers, an ambulatory care center, auxiliary hospitals, a Health Canada nursing station, community ambulatory care centers, community mental health clinics, nursing homes, regional contracted practitioner offices, and subacute auxiliary hospitals. So that's a very broad list. Pretty much any public facility will have the Z code requirement attached to it. So what are the new Z codes for family medicine? Those will focus on the 0303 AZ for your limited office, the prenatal visit, 0303 BZ, your 0304 AZ, which is your comprehensive visit. If you're doing palliative care, your palliative care visit also has a Z companion. If you have a consultative practice, your minor consultation and comprehensive consultations, as well as obstetrical consultations, will be impacted. And then the prolonged consultations are specific specialties, but if you are providing any psychiatric treatment in public facilities, again, the 0819GZ will be for the services in that public facility rather than 0819G. So again, Z codes, any public facility. There is work being done by AHS to identify those places where they and the physician have an overhead agreement in place and where they have jointly agreed and applied to Alberta Health for a separate facility number, which Alberta Health has granted. If the physician is working in one of those separate clinics, the services they provide in that clinic will be unaffected by the Z code requirements. However, once that physician leaves that clinic, any services that they would provide in the emergency room, in an inpatient ward, or an outpatient clinic other than that specific office facility would still be required to be claimed under the Z code. So I think there have been some misunderstandings about that. So that's just meant to provide some clarification about that. If you find that the service you've been billing pre-March 31 doesn't have a Z code equivalent, so 0304C, your hospital admission, is an example of that, then you would continue to use 0304C for your post-March 31 claims. Just another thing that you may find some requests coming through your offices, imaging services that have been referred by a chiropractor, physiotherapy, or an audiologist were uninsured on March 31. That means that that group can continue to refer those services to DI, but patients would now be responsible for the cost. So just a heads up, you may start seeing some of those stream through your office, and you know, just an awareness that if you refer, that is an insured service. But again, you know, then you would be responsible for the follow-up on that according to the college. So just factor that into your consideration about whether you will make that referral yourself. So I'll now pause and answer any questions that have come in about the March 31 codes. So the Z codes, you should not stop billing right away. You should continue to use them. Alberta Health will go back and reassess those that have been paid at the lower rate over the next few weeks. So you will, and your office billing teams will see some reassessments to bring the rates that you were paid for those Z codes that you've claimed up till now up to the appropriate rate. I anticipate that it's going to take them a few days to make those rate adjustments. So you may see a few lower payments over the next week or so while they get their systems programming completed. And then they have said that they will go back and reassess all of those Z code claims to pay them at the higher rate. For good faith claims, how can you check the healthcare status on Netcare, and does ULI not equal PHN? So yes, ULI and PHN are the same thing. One thing to watch for though is in AHS facilities, often what you will see is what looks like an Alberta Health Insurance number assigned to the patient, and that's for tracking hospital records, diagnostics, and so on. But if you check farther, you will see that that patient has coverage from another province. How do you check healthcare status on Netcare? There is a patient information tab. Where I have seen it is in the lower right-hand corner. There's an access button that you can look there. And then when you get onto that tab, there will be some patient demographics and a date that is called, just kind of anonymously called effective date. That effective date is the date of their healthcare insurance. For good faith claims, what about patients from other provinces that require hospitalization for COVID? A couple of things. If that patient has health insurance from the other province, then you would continue to make that claim as you would for any other out of province patient. So what that means is you will claim under their other province's health insurance number. You'll indicate using the other province indicator in your claim what province they're from, and then you'll provide demographic information, their date of birth, their full name, and their home province address to support that claim. And if you have challenges with that, please get in touch with us so we can help you work through that with Alberta Health. At this point, we don't know how they're going to be managing that coverage issue, but they have, just so everyone knows, been very clear with us that at this point, you may not claim any of the virtual codes for services to patients outside Alberta, with the exception of patients from the Northwest Territories. Northwest Territories and Alberta have agreed that, excuse me, that Northwest Territories will pay for virtual services by Alberta physicians to their patients. 90 days is resolution of the claim included in the 90 days. So what that 90 days means is a very similar definition to the 180-day definition, which is 90 days from the date of service or from the date of the last communication with Alberta Health. So if, for example, Alberta Health holds on to a claim for 30 days past the date of service, then you would have 90 days from that 30-day mark to then respond and talk about that with them and resubmit your claim or submit any changes to it. The health claims process is lengthy. If you provided that service before March 30th, it will be paid, but their manual processing is lengthy. One of the things that they are doing is if you have a very significant number of claims, they will make a special exception for your business arrangement number to submit your claims with no text. If you're in that situation, please get in touch with me at the AMA office and I can help you work through that with Alberta Health. I'm just going to check other questions that are occurring here. All right, so I'm going to go on to the next set of questions. And if no one has any other questions for me about this part, let's plunge into the, how do we talk about the general schedule? So first I'd like to talk about the rules because they really set the foundation for how the schedule works and what the issues and questions are. So we've talked a little bit about what to do if you need help. Alberta Health publishes a physician resource guide. That's much more of a technical manual, but it can help you, for example, with what pieces of information do I need in addition to what I would usually provide if I'm billing for an out-of-province patient. You can have a look at the scheduled medical benefits procedure, a price list, and all the pieces if you like. Alberta Health also will support you and provide responses about particular claims. And I'm sorry, I didn't put their new email address in this. Since they have all their staff working at home, this phone number is just gives you an email address, and I will make sure to pass that along through Mary Lee to everyone who participated tonight. But the other thing I would say is the AMA provides support and advocacy for you when you're having a problem with Alberta Health, when you don't understand a claim situation, why it's been declined, why it's being held, or when you just have questions about how to appropriately present a claim for a particular issue. So when you have that, then when you have a challenge, and I see one of the questions is, what happens if they don't reply by email for 2 weeks or more and they don't pick up the phone? That's when you should come to us, particularly if your billing date is getting close to that stale dated time. So at that point, really important that you send us a question, and we'll work with Alberta Health to try and get that answer for you. So verifying coverage, you can use NetCare, or in your office, you can have your team use this phone line. I would advise phone. NetCare is a much quicker and easier way to do that. You should be checking all of your new patients who come in. You should check those who you haven't seen recently, or those who've had a change in their life. So their marital status has changed, they're young adults who's emancipating from their parents. And then make sure when you do that, you're checking the effective date of the coverage, and that should be, again, in NetCare on that patient information page, and it'll just say effective date. For those of you who practice mostly in central and south central Alberta, there are a few Albertans who have formally opted out of healthcare insurance. That's usually political or religious beliefs. For those patients, you would bill them directly, and you are not limited in that case to the schedule rates, because they have formally said that they do not wish to participate in the healthcare insurance plan for Alberta. And then make sure you're aware of the good faith claim discontinuance, and you are checking for those hospital patients that they have healthcare insurance, and you are sending them on if their problem is not urgent or emergent. So for reciprocal billing in your office, you should be having your office staff check this link to see, is the card the patient is presenting in the current format? And do you have you looked at their identification, their picture ID, to make sure the name on their health card and the name on their picture ID match? If they don't, then I would bill the patient, give them the information that they will need to recover that amount from from their provincial health insurance plan, and then you'll be able to be confident that you have been paid for your service. The patient can then recover from their other province plan. If I come into your office and I present an invalid health registration number for Alberta, so it's expired or I can't present a number, you can bill me and then make a pay-to-patient claim. We discussed that previously when my coverage is in place. It's important that you check that health insurance number before I'm in your office or in your exam room, because that gives you the opportunity to have your staff explain, and you follow up with a patient who doesn't have health insurance or can't present evidence. In the hospital, if you have a claim refused for eligibility, sometimes we can intercede with Alberta Health to get that claim paid. It's not clear to us right now whether they will continue to do that with their March 31 changes, but do send that on, and then we will try to work with you and them to get that claim paid. Some other foundational rules, time-based services. So I know that a lot of you probably aren't doing this right now, but there is a rule that says you need to keep track of the start and end of your day, each day that you will claim a time-based service, and you need to retain that in chronological order. So you can do that by having a spreadsheet. You can have a logbook or a calendar, as long as you would have that access to that record for 6 years or more. Oh, I'm really sorry, everyone. Apparently spring is harder on me than I thought. So how do you do that? You make sure that you're recording start and end of your day, that you exclude any time for breaks, but make sure that you're including any time that you spend after your office or after clinic hours on work related to patients that you've seen that day, because you want to incorporate that time into your visit patient complexity time that you're going to, into the complexity modifiers for your visits on that day. And then you want to be able to retain that for 6 years, because that's the requirement for your billing records. So for your delegated services, we talked a bit about this. The schedule really is intended to pay for your direct services to patients. But there are some exceptions. And so those can be services that are technical services done in your office. So some of those are the pulmonary function tests and so on. Your allergy desensitization or your flu and pneumo vaccinations that are given by a nurse in your clinic also can be delegated. For physicians in training, those of you who have typically had residents working in your office, you either must directly supervise that visit, so you are in the room with the resident and the patient, or you must go into the room and in the presence of the patient, review with the resident the exam, the history, the diagnosis, and the treatment plan. And that is an important part of this, because if you haven't done that, then you won't be able to make sure that your record of that visit demonstrates that you were in that room. All right, so immunizations, what can you bill for? You can bill for your flu immunization, pneumococcal vaccinations. You can bill for your tetanus vaccinations if you yourself give that vaccination for wound management. And if you have children with pre-existing conditions, that means there's a severe risk of complications if they have that vaccination in the health unit, then you absolutely can make sure that you're giving that injection in your office. Any other insured injections, so B12 and so on, must be given by the physician in order to be claimed. And then just a reminder, travel immunizations, Gardasil, hepatitis vaccinations aren't insured, and so they can't be claimed. And you should be billing your patients for both the vaccination and the cost of the vaccine itself. Encounter definition is a similarly foundational requirement. So encounter means each separate and distinct time you see the patient and provide services in a given day. So that means between 12:01 a.m. and 11:59 p.m., anytime you see that patient that is not a continuation of a previous service would be an additional encounter. So what does that mean? If the patient comes to your office for a visit, they're sent away for some diagnostics, and they return on the same day, all that is one encounter because you haven't concluded that encounter with them. You interrupted that encounter to have them go away for some diagnostics. If you see the patient in the morning, initiate treatment, they return this later the same day because their problem is worse, so they have a new problem, that second visit is encounter 2. For virtual care, Alberta Health has been very clear that only one virtual care service is claimable per day, and that it's not claimable on the same date as an in-person service. So what I would recommend, if you have a virtual visit with a patient in the morning, arrange for them to come to your office in the afternoon. Oh, I'm so sorry, everyone. Then you would incorporate that time for your morning virtual care visit into the complexity modifier for your in-person service in the afternoon. Let's talk a bit about visits and consultations. So I'm sure all of you are really familiar with the 0303A. That one is an examination and a history focused on the presenting problem that's eligible for your CMGP modifier. So this is probably the visit that is most commonly claimed in your office. Not many of you will build a brief visit, but it is available in a case where you would have a minimal history and little to no examination of the patient, making sure that there are very clear descriptions of the exam and so on provided. For your 0304A, and I'll just remind everyone, this complete head-to-toe all-body systems rule has been in place for a considerable amount of time. This rule doesn't say that in order to bill any visit, you need to have that head-to-toe examination, but it does mean that in order to bill an 0304A comprehensive office visit for a patient, you need to have this complete head-to-toe examination of all body systems. It's not payable more than every 365 days, and it must include a care plan. When all that work related to that, including review of the patient chart, any diagnostics, writing a referral letter or following up on patient care afterwards that occurs on that same date of service, takes 30 minutes or more, you can add your CMX C30 modifier. For your comprehensive prenatal visit, that would be a comprehensive exam focusing on the pregnancy. But again, it's not claimable within 90 days of your 0304A comprehensive visit, claimable only once per pregnancy, and it includes initiation of the prenatal record. If you are not creating that prenatal record, please do your colleagues who will be creating that record a favor and not claim the 0304B. If all that work on that same date takes 30 minutes or more, then again, you'd make sure that you're adding your CMX C30 modifier to that. If you have a consultative practice, so you have a special skill set, you're doing low risk obstetrics or something like that, and you are having patients who are referred to you for minor problems or referred to you for a repeat consultation, make sure that you're using the 0307A or B appropriately. Both of them are eligible for the CMX B15 modifier if your work on that day takes 15 minutes or longer, or the CMX B30 modifier if your work that day takes 30 minutes or longer. And again, those would be one or the other requirements, and each of those would have to meet the consultation requirements that we'll talk about in a few minutes. The CMGP modifier is, again, a key modifier and probably the one that most of you are most familiar with. The requirement there is that to bill the first unit, you have spent 15 minutes or more on management of the patient's care on the date you see them. I'm really sorry, management of that care on dates before or after that patient sees you is not able to be incorporated in this. So if you're doing any work that is related to that patient, if you can do it on the same date as you saw them, then that makes it eligible for the CMGP modifier. Make sure that you know that the second and subsequent units are billable at those 10-minute thresholds. So your first unit can be billed as soon as you touch that 15-minute threshold, second unit at 25 minutes, third unit at 35 minutes, and so on. So that means if you have 10 minutes direct contact with your patient. Then you have a conversation with the diabetic educator in your PCN, and then you spend 10 minutes writing a referral letter to the orthopedic surgeon because the patient is having problems with their knee. You would bill your 0303A for the office visit, plus your CMGP 02 modifier. All of the visits on the next couple of pages are eligible for the CMGP modifier, so don't forget that it can be claimed in addition to the workers' compensation document visit, the limited visit, so your 0303A, your prenatal visit if you're doing prenatal care, the 0303B, your postnatal visit, either of your home visits, the first or repeat, and your visits to patients in assisted living or designated assisted living, as well as your minor consultations. So just remember that for your home visits and your assisted living visits, that 03NA plus your CMGP would account for the clinical service, so your clinical time with the patient. And then the 0303 NA, NB, or M each have an additional bump to account for the need to travel to the home or travel to the assisted living. So only your clinical time, your visit with the patient, charting, making sure that you've reviewed any diagnostics can be claimed along with the CMGP modifier, but please don't include your travel time in that CMGP modifier. That's not the intent. So definition of CMGP is really a complex patient visit requiring 15 minutes or more of physician time for the clinical work, and that's both direct and indirect clinical work. There's been a bit of a misunderstanding with Alberta Health, thinking that complexity in this description relates to patient complexity. And it does not. That's why visit is in there. That means that the visit is complex, and complexity in this case is really about how much time was required to review diagnostics, do your charting, write your referral letter. All that work done on that same day, plus coordination of care, can be included in your CMGP time. So make sure that you're billing appropriately according to the thresholds. So 1 unit at 15 minutes, 2 units at 25, 3 at 35, and so on, up to 10 units. CMX C30 goes with your comprehensive group of codes. So your comprehensive office visit, your prenatal visit, your hospital admission, your long-term care admission, and so on. All are eligible for the CMX C30 modifier. And again, complexity in that case is all about how much time was required to complete the work related to that patient on the date you saw them. What's eligible for that? Your hospital admission, comprehensive visit, your preoperative history and physical, your comprehensive consultation, and so on. What can you include in the time for your comprehensive visit? Reviewing your patient chart, talking to and examining the patient, doing your charting, reviewing any diagnostics, coordination of care, any time that you spend related to the care of that and management of that patient on the date you see them, excluding time that you would bill for using another code. So one example is the 1399BA, the Pap smear. You would exclude that time for the Pap smear from the calculation of your complex modifier time. In the case of a consultation, so you're billing an 0308A or 7A or B, you would include the time for drafting your consultation letter, either dictating it or writing it yourself in that time. And if you are writing a referral letter to a consultant, that time also can be included in your complexity time as long as the work is done on the same date that you see the patient. And just a note, you can't include, so can't as in may not, non-physician time, so your intern or resident time, nursing time, in your complex modifier time. I get a lot of questions about what's what's the definition of a consultation? And I know physicians among themselves may use consultation in a variety of situations, but in the schedule it has a very specific and limited meaning. And so what it means is that the patient has been examined by a referring provider, and that can be a physiotherapist, another physician, an audiologist, and so on. The referring provider specifically, either verbally or in writing, requests the consultant's opinion and advice, and then the consultant does a full or problem-focused history and physical examination, may order lab and diagnostics, talks to the patient about treatments and gives them advice, and in some cases may talk to the referring provider, and then they provide a written report back. All of these criteria have to be met in order to claim a consultation, and if you're missing one, so you're missing the referring provider, you're missing the consult letter back, then it's not a consultation. This is a list of and requirements. Let's talk a little bit about telephone and other communication with physicians. I saw some questions in here about communication with family and so on. So if you have patients who are in hospital, they're in an assisted living or designated assisted living location or lodge, they're receiving home care and you're getting calls from your home care worker, they're receiving hospice care, you're getting calls from a hospice worker, or you're getting calls about them from a public health nurse, then the 0301 NG, H, or I series can be used according to the time of day that you have the conversation with the other worker. So if you speak to them between 7 and 5 p.m. on a weekday, you would bill the NG. If you talk to them in the evening of a weekday or on the weekend, NH. And then any day of the week, if you talk to them between 10 p.m. and 7 a.m., you'd bill the NI. There are different rules for each one of them, but it's important to remember that for these, residents are not considered to be part of the group from whom these calls can be billed. If you are a family physician who provides obstetrical care, you can bill for advice to active treatment workers or nurse practitioners in relation to an obstetrical outpatient using the 0301 LM series of codes. And just a reminder, when you're billing for claims for either of these groups of codes, for patients who are in a facility, the requirement is that the physician be outside. So if you're taking this call from a hospital facility worker, you yourself must be outside of the hospital facility, and the facility staff member must be the individual who's initiated the call. For all of these phone advice codes, the requirement is that it be initiated by the worker, except for long-term care. For your long-term care patients, if you receive diagnostic results or other information that means you need to change that patient's order, you, the physician, can initiate that call to long-term care. For all of these codes in any situation, you can claim a maximum of 2 per patient per day, and they can be claimed in addition to other services you might bill on that same date. So if you visit the patient in the morning, have a call from the facility worker in the afternoon or evening, both of those services may be claimed. Again, keep your documentation for this and make sure if you are depending on the hospital record or the long-term care record that you're checking the next time you are there to make sure that there is documentation of that call in the record and that's appropriately captured. When you're billing this code, the location of service is where you are when you take that call. So if you are at your home, you would put the home. If you're somewhere other than your home or office, you would put other. And if you're in your office, you would use your office functional center and facility number. If you are taking calls from home care, just know that you can also use this for fax exchange with home care, or if they come to meet with you in your office. If you are using this for nurse practitioner calls, they must be an independent practice of working in a nursing station where no physician is present in order for you to claim. Advice to pharmacists is something that we're getting a lot of calls with about right now because of the virtual care environment. And just a couple of things to think about. The intent of this code is that it be initiated by the pharmacist. You can't use it, and that means you may not use it when you are faxing or otherwise communicating with the pharmacist at your initiation in order to provide a prescription for a patient. The intent of this code really is that the pharmacist is seeking your advice and opinion, or to inform you when there are changes to your prescription, when the pharmacist is initiating a prescription or a care plan or a med review. So you can't claim it for prescription renewal. Typically, the timeline on that is 2 weeks. So we would typically say that if you were getting a request from pharmacy to renew a prescription, you shouldn't do that for longer than 2 weeks. During the pandemic, we've extended that to 30 days just to match some of the requirements that are happening. In the case of this code, you would need to communicate either by telephone or by fax directly with the pharmacist. So that means you would need to speak directly to the pharmacist, or if you're responding to a fax, you would need to write in your handwriting on the fax that you agree with their substitution, if they're substituting a generic for a brand name drug, that you are giving different instruction if they have notified you of a drug interaction problem, but that you yourself are recording that on that document. You can bill a maximum of 1 per day, in addition to any visits that might occur, and just make sure that there is documentation in the patient record of either that phone call or that the fax is being scanned and saved, or saved in your paper record if that's your choice. So there are also lots of calls about the physician-to-physician phone calls. The requirements are very similar in both cases, and one of the primary questions we get is, can I use this for calls to and from residents? And the answer is, I'm sorry, no, because in this case, residents are not seen as a fully licensed and practicing physician. So please limit these to only conversations with your physician colleagues. When can you claim? A call's been initiated by the referring physician. The consultant has provided an opinion and recommendations for treatment and management of the patient, and that service is provided using either a secure video conference system or telephone. And there is a privacy impact assessment if you're using that secure video conference model. It's not claimable when the purpose of the call is to arrange for a transfer of care within 24 hours, unless you're transferring the care of that patient from one facility to another for management and ongoing treatment. It also can't be used to expedited consultations within 24 hours. So if the purpose of that call is to say to you, this specialist, please see this patient within the next 24 hours, then neither of you are able to bill for the physician-to-physician phone call. Likewise, it's not to arrange or seek information about lab and DI investigations, or to talk or inform the referring physician or of results of diagnostics. Again, you can claim for a maximum of 2 per day. Make sure you have that documentation. And in order to use that telehealth video conference, both physicians have to be at that regional telehealth facility. And if you are the referring physician, make sure you're giving your consultant your PrEP ID unless you're using the rapid system, in which case that gets provided to them. There are also e-consultations. So if you have a problem that is not urgent, you can submit an e-consultation through Netcare or other secure services. So if you're using AHS email addresses, it's very secure, so you can email your specialist colleague. Netcare also has the e-consult service. So you, as the referring physician, would document and claim for this on the date that you send the request. And then your colleague, the specialist, would document and bill for their companion code when they are providing the response. Again, the same requirements, not for expedited consultations, not for lab or DI, investigation arrangements, or to talk about results of diagnostics, or to arrange transfer of care. It really is intended, both the physician-to-physician phone or video consult and this, to allow the seeking of information by the referring physician and the provision of information by the consultant to occur in electronic or virtual manner when the patient is not intended to be seen. So what does the consultant claim? They would claim the 03010. Again, it requires a referral practice ID like most of the consultant codes. And again, make sure that the request and the response are in the patient record. And the intent of this is not that there's going to be a major consult within the 24 hours after that patient has been referred, unless that patient is coming from an outside facility. Both require, both the e-consult and the physician-to-physician consult require that there be advice given about management of the patient prior to that transfer, or with the intent that that patient stays with the referring physician for the duration of their care. Family conferences and so on. So if you have a hospital, ER, outpatient or long-term care patient, and you need to have a conversation with their family who either lives at such a distance that that conversation can't occur in person, or who has mobility challenges themselves that mean they can't reasonably come in and talk to you, you can bill the 0305 JP for that family conference. It's not intended to be used again for relaying lab or DI results or arranging follow-up care. And make sure that you're retaining that information in the patient record. This communication could be about getting additional information from the family that's required for patient management and care, when that timely communication is really essential to make sure that the patient is receiving appropriate care, or if you need to have a conversation about organ and tissue transfer and collection. For community patients, there is a similar code. So going back to the earlier question about talking to the parent of the child, this would be a code that I think would be appropriate. I recognize that the rate is not very attractive, but when you have not specifically seen that patient, there hasn't been that direct physician-patient contact in during the pandemic that would allow you to claim for the virtual code, I really would encourage you to use this code. Again, not for DI and lab results, and make sure that you're keeping your documentation about that. There are also team conferences that can be claimed, and I just would question and really caution everybody to make sure that you're clear about the family conference and its intent. So if you're going to bill 0305 JB, make sure that that's a formally scheduled family conference, not an accompanied visit. So that means that you can see in your schedule that patient A's family is coming in to have a conversation with you about their care and management this day at this time, and that they are not accompanying the patient to that conversation. You can bill a maximum of 3 hours per year per patient. And again, that formally scheduled requirement is there. Make sure you're documenting who attended and their relationship with the patient. So your record would say family conference regarding patient A, attended by patient A's daughter named B, son named C, spouse named D. And then make sure as well that you're documenting your time, not that you have to submit it to Alberta Health, but it's an important part of your documentation of that requirement. And then you would bill per 15 minutes for a major portion thereof. That means that you could bill your first unit at 8 minutes, your second unit at 23 minutes, your third unit at 38 minutes, and so on. The family conference about acute care facility inpatients is not required to be formally scheduled. So this could be a situation where you go to see your patient, the family is there and they ask to speak to you separately. Can also be used for emergency patients or auxiliary nursing home patients as well. Again, that maximum of 3 hours per patient per year is there, and it's intended for patients whose condition really requires that there be periodic family conferences to discuss their care planning and so on. Again, not intended for bedside discussions with the patient family. For team conferences, they, no matter what the environment, need to be formally scheduled. So you would need to see again in your calendar that Tuesday afternoon at 4 o'clock, for example, team comprised of A, B, and C was getting together to discuss the care of patient D. It's intended to be with the team who is caring for that patient, so that would be physicians plus other care providers. Not intended for reviewing physicians' panel or doing any panel management activities. Must be booked to discuss a specific individual patient. And in order to claim, the discussion of that individual patient must be 8 minutes or longer. If more than one physician is attending that conference, text is required to identify why that is required and who the other participating physicians were. Again, 3 hours per patient per physician per year is claimable, and you may not claim that at the same encounter as a visit. Outside of the virtual care grant, there are also 3 codes that you can use for various types of communications with your patients. These are probably familiar in some ways to all of you. So the 0305JR can be used for calls directly to patients at a maximum of 14 per week per physician. The 0301F can be used for any secure electronic communication. So that would be email or secure texting. Again, 1 per patient per week to a maximum of 14 per week per physician. And that 1 per patient a week extends to across the 3 codes, 0305JR, 0301S, and 0301T that we'll talk about in a minute. So that means that you could bill 1 of that group per patient per week to a maximum of 140305JR, 140301S, and 140301T. You can't claim a visit within 24 hours of that e-communication, and make sure that you have documentation in your patient record. It has to be claimed for physician to patient direct contact, not when there is an intermediary involved, and it's not claimable for any inpatient. For either this or the 0301T, the secure video conference, make sure that your privacy impact assessment has been updated to include this or did include it originally, and that the OICC has either accepted it or it's in the queue for that. For all of these, you need to have an established physician-patient relationship, and you need to have seen the patient within the previous 12 months, particularly the video conference, because there is that proliferation of Babylon and Maple and all the other video conference accessible platforms. Alberta Health has imposed this must have an existing relationship requirement. Again, you can bill 1 per patient per week to a maximum of 14 per physician. For INRs, those of you who have patients on anticoagulant therapy, you can claim up to 2 calls about managing their therapy per month per patient. So you must document that call. That call can be made by a member of your office staff, but it still must be documented. And that work includes ordering the blood tests, interpreting the results, and adjusting their dosage. So when that call is made to the patient, there needs to be some indication of advice about their dosage. So that could be increase, decrease, or maintain the same dosage. For other visits, I'm sure all of you are familiar with the psychotherapy code. So just a reminder, 0819G is only for direct contact between the patient and the physician. So if you choose to do your charting at a separate time, just remember that that charting time may not be included in your 0819G time if it's done when the patient is not in the room. Again, this code is time-based, and you're going to claim per 15 minutes or major portion thereof. For palliative care services, those of you who are providing that, the definition is that the patient is suffering from a terminal disease or illness, and there are 3 codes to be claimed for direct care. That means direct in-person care to the patient, indirect care, which can be a team conference with other physicians and family, a discussion with family or allied health providers and community agencies. Whatever that team conference would be, you would bill under the patient yearly, and again, per 15 minutes or greater portion thereof for both the O305I and the O305P. O305U can be used when there's a second physician attending a palliative care conference because they've been involved in the care of that patient, again, per 15 minutes or major portion thereof to claim. Your comprehensive visit for admission to an addiction treatment facility is also a code that you can bill. Make sure that you're checking the link in this document because only the facilities that are listed on this link are admissible and can be claimed. If you are admitting patients to other facilities that are on this list, the forms would be uninsured and they should be billed to the patient or a third party. If you're doing pre-op history and physicals for insured services, remember that you can claim your CMX C30 in addition to the O304M, and make sure that you're maintaining a copy of the form in your patient's chart. If you're doing these for dental services, there are some very specific restrictions, and those are that it can only be claimed in the following situations. So the patient has a mental or physical disability that is severe enough that it precludes the performance of that service under a local anesthetic, or the dental service is insured under the dental benefits regulation. So that's primarily oral and maxillofacial services. The other situation is if the patient has a compromised immune system, or they are preparing for organ transplant or open cardiac surgery, you can bill for their dental work in that case. Or if it's a child who is under 17 and they are heading toward extensive dental rehabilitation, which is defined as an hour or longer, then you can bill that. If you are being asked to do a pre-op history and physical for a healthy adult who is having dental surgery or extensive dental work, then that pre-op history and physical, as well as the anesthetic, would be the responsibility, payment responsibility of that individual patient. And just a reminder, you should no longer be seeing any requirements for these forms to be completed for patients who are having cataract surgery under local anesthetic. The comprehensive evaluation for the capacity determination, again, remember that's under the Personal Directives Act, so it's really about patients' ability to make decisions about their medical care. It's not about their legal capacity to manage their legal and financial affairs. The benefit includes witnessing agents or service providers' assessment of that patient, if that is the model that you're using. And remember that it can also be used to determine when someone is regaining capacity to make those decisions for themselves. Quickly, let's talk about procedures. So minor procedures and minor diagnostic procedures in your office. You can bill a minor procedure in your office visit if they are for unrelated diagnoses. If you're doing a procedure that includes the removal of sutures later by you or by someone in your practice group. So if patients come to your office, they have a biopsy, they come back 10 days later, they're having the sutures removed. If you or a colleague in your same practice group removes that suture or those sutures, you may not claim even a visit for that unless the patient is also contacting you for another problem. So at the same time, you're monitoring their blood pressure and so on. If that patient has sutures that are placed in the ER, for example, and they attend your office for removal, you can bill a visit for that. If you are doing a procedure like suturing or taking a biopsy, Local infiltration of the anesthetic is included in that benefit. I probably don't need to tell this group, but I do get some crazy questions. And so I always like to remind people of that. For exceptions to the visit and procedure rule, the section of general practice has done a lot of work in the last few years to make sure that certain procedures may be claimed in addition to an office visit. So I won't go through them in detail, but that includes your pap smear, your IUD insertion and removal, your pelvic exam with a speculum. It includes joint injections and removal of warts when they're insured, as well as removal of sebaceous cysts. So if you are doing a minor procedure in addition to your office visit, have a look at this list. Make sure you know whether you can or cannot bill it in addition. For diagnostic surgical procedures, those are typically biopsies. In your office, you can claim them along with either a visit or a consultation. In the hospital, you can claim either the visit or the biopsy, but not both, or you can claim it, as in may claim it, with a consultation. How do you know if procedure is a minor plus, or a visit? If you look on the AMA Fee Navigator, you want to look in this field here called category. M+ is a designated minor procedure, M is a minor procedure, and anything that has a B category here will be subject to that 50 visit cap in urban and outlying areas. Warts, treatment of warts is not insured except for situations listed here. So you have an immunosuppressed patient, you have a precancerous skin lesion and so on. That's the only time warts are in insured service. Otherwise, you should be billing the patient if they don't have any of the conditions of wart types listed here. Foreign body removals, just make sure that you know whether it's a minor procedure that can be claimed in addition to a visit, or whether it's an M+ procedure like the removal of foreign body from the vagina that can be billed in addition to your visit. So I said I would give you some resources. If you look at this page, and we will make sure that this slide deck is available to you, the AMA Fee Navigator trend, if questions about particular fee codes, you can also billing advice at albertadoctors.org for advice, or you can email Darcy Shade, Marissa Bonicelli, or our email addresses are at the beginning of this presentation. Alberta Health does, and it is important that you have a look at them when there are changes. So you can set up a Google alert, for example, to let you know when new bullets are added. And then if you want to have a look at the entire schedule of medical benefits, you can go to that link that's listed here, the fees for link. So I will just pass it back to Mary Lee. I'm going to start having a look at, are there particular issues that you've been seeing in the chat that are coming to the forefront?
Thank you, Norma. So there was a bunch of questions coming in. We did our best to get them all into that document. Jocelyn.
Okay, so so maybe I'll just start kind of going through. So there's a question about 0301S. Does the PIA have to be processed and accepted or just submitted? Because the queue at the Office of the Information and Privacy Commissioner is about a year long, just needs at this point to be processed and or to be submitted. Watch though for comments coming back that require any adjustments or any questions coming back from them so you can respond to them in a timely manner. Let's see, I'm just going to go through here. 0305JA. So there is a question about whether it can be used with nursing when there is a social issue regarding the patient. I would say with caution, yes. So people ask why we're quite cautious at the AMA in terms of the advice we give, and that's because we're very conscious that Alberta Health can and does audit physicians, and we'd never want to give advice that will place you in jeopardy. So for this patient, I would say make sure you're documenting that there is this conversation, that your nurse is involved in the care of that patient as well. The 0305 JA is meant to be a team conference where the members of the team caring for the patient are coming together to have a discussion, and then they will go away and separately implement the agreed to actions on their part. So you should typically see that there will be physician actions, maybe nursing action, maybe chronic disease manager actions coming out of a team conference by the patient. And so make sure that you're seeing that the members of the team are there and that they're all coming away with some actions to do with that patient that they have discussed at that time. And just make very certain that that conference is scheduled in advance, that you're spending at least 8 minutes talking about that individual patient and their care. And there is very clear documentation in the patient record of the discussion, the assigned work coming out of that, and the expected check-in dates and so on. You need to make very certain that it is not at the same time as a patient visit. 0305 JA is meant for the team coming together formally to have a discussion about the patient, not as a team-based visit with the patient. And then there's a question about, does that apply to 0305 JD? And I'm not sure I understand the context of that. So perhaps whomever asked that question could come off of mute and just clarify what they're looking for there. That would be really helpful. Do we have people able to come off mute?
Probably if we promoted them to panelists, but I don't know who asked the question.
Okay.
I'll scroll through quickly and see if I can find it. 1 second.
Okay, that'd be helpful. Thanks. All right, I'm just going to pop back to my question summary here. All right, so multi-system disease and our multidisciplinary team members, I'm sorry. So that would mean you have nursing staff, chronic disease managers, PT, OT. Multidisciplinary team means more than a physician-based team. So there are more professions with a health background. So it could be social workers. You could have a social worker, an NP, and an OT and a chronic disease manager, all sitting down with the physician to have a conversation about the care of a particular patient. And social issues, that means that socioeconomically the patient is perhaps struggling. They might be struggling with housing. They might be struggling with managing their life. They might be struggling with appropriate food or housing. So that's really what that means. It's not meant to be an exclusionary, but it's meant to help people understand that this is not meant for the situation where physicians are sitting down and going through with patients to determine their care, and that is happening with their clinic nurse. Or in one very unfortunate situation we have seen recently at the AMA Peer Review Committee, it's very apparent that the physician is filling a team conference for each patient seen in the clinic every day, and we suspect, based on feedback, that is when we are having a conversation about, please ask the patient to return in 30 days, please ask the patient to rebook their appointment when their medication is running out, and so on. So really important that the purpose of that discussion be to manage that patient's care, and that each member of the team who is attending is involved in direct management and providing care to that patient.
Norma,
There's a question.
sorry, I found the participant. It's Megan Manning that asked the question. Megan, I have allowed you to speak if you could clarify your question.
Can you hear me?
Yeah.
Oh, okay.
Can,
So
Megan.
hi, I was just wondering for the 0305J on the slide page, it said that that needs to be billed in or you have to use a separate encounter number than say the patient visit. I'm just wondering if the same applies for the 0305JD interdisciplinary meeting code as well. That's I think a 5-minute one.
Yes, and actually all of those would need to be at a separate encounter from the patient visit.
Okay, thank you.
And the intent is that, the intent is that they are very, they're very distinct events.
Okay, there is one question, Norma, that I would like to draw your attention to. That it's by Zane, and he asked me for some clarification because he's asked the AMA already, but the question or the response that came back, he's still unclear of how to bill it. So you'll see Zane at 659 in our document here. I've got it highlighted if you can see my highlight.
That's perfect. Thank you. Ed on the phone consult with modified use. Okay, let's see, modifiers. Oh dear. You know, I'm really confused about that, Dr. Zane, because there is the 0303AZ would be a code that you would use when you saw the patient in person in a public facility. So if you were seeing them in the emergency room, in an urgent care center, or an advanced ambulatory care center, that would be the situation where you would use the AZ. And then 0303CV would be more used for a virtual visit with the patient. So I'm just a little bit unclear about I wonder if you could help me with when, with using the AZ versus the CV. If you are seeing a patient in person, you would use the 0303 AZ in a public facility. The CV is really for virtual contact. So see, it's Dr. Barani. I want to come off mute and we could just make sure that we're really clear about the question.
Sorry, I've taken you off of mute, Zane.
Yeah, hi there. Sorry.
Hi.
Yeah, so it was in regards to video and phone conferences. So initially I had contacted the AMA to say like some of my video and phone conferences, because I'm having patients do self-exams or setting up videos via phone and starting into this new like COVID technology, that they were running quite long for me. And so the initial question to AMA was about modifiers for the CV code. And that's the response I had received to switch over to the 0303AZ and put modifiers on there. I started doing it, and then I realized some of them were accepted, some of them were denied. So once again, I sent an email in, and that was the email I responded back to, saying to use the 0303AZ as a GP. But the information online and between my colleagues wasn't consistent with that. And that's really the intent for joining this group tonight, is to get some clarification on whether I should be using that code, because I'm not seeing a unanimous kind of from my colleagues.
Okay. So I'm really glad you shared this. I think I need back to our team who's answering advice emails and be really consistent and clear with her, because if you are doing a virtual care visit at this time, you would need to use the 03CE, and unfortunately Alberta Health has not yet agreed to use the CMGP or any other modifiers along with that. We have been pressing them very strongly, with strongly advocating for them to allow the modifiers to be used with those codes. But at this time, they have agreed to do that. would be to use telephone or video patient. And I apologize that you were given confusing advice. I will go back to our team member and make sure they're very clear about that.
Well, thank you so much for taking the time to answer that. Much appreciated.
All right, so I see some questions about the WCB and the visit cap. Really important for your visit cap that you're keeping track each day of how many B category services you're billing. So that would be, I bill 03s, I've billed 4 03-As, I've done 10 phone calls with a patient, and so on. So you need to make sure you're very clear about that. And then on a particular date, say you're getting very close to your 50 maximum and you think you might go over. I make sure that for that day, on your weekly submissions to Alberta Health, when those go in on the Thursday, you submit all your higher value services. So you're going to submit your 0304, your 0303A, and you're going to hold off on your phone calls and submit. So if you have to take any deduction on your lower value phone calls rather than taking it on your higher value visits and so on. There's also a question about the WCB speeding up on claim rejections. They can be very slow in rejecting those claims, and Alberta Health hasn't changed the requirements. So when you get that rejection from WCB, if you send that in to Alberta Health with a notation that WCB rejected this claim on this date, at time they ask you to provide them with a corroborating letter from WCB. You can put in that case, but they will accept those for up to 90 days after the WCB's rejection of that claim. It may take a little while to work through the process, but they have to accept them within that 90-day period. B category services. So I think that you should have an idea of how to find that. You would look on the navigator at the category area, make sure it says B. Each one of the services that you do in your office then count toward the 50 threshold. And then remember that from 51 to 65, you'll have your services reduced in payment by 50%, and then 65 and older will receive no payment at all. The number of services you can create for OVOIJR, that's the phone call to patients. But remember that your virtual care services are not part of the cap. They don't have a max of 14 or any other number per week. So for your 005JR, I would save those and use those when you're contacting patients to talk about lab results or something that doesn't really fit with the requirements for the other virtual care codes. The other thing I'll just mention is when you're billing the 0301AD, that code needs to have as one of its diagnoses the COVID diagnostic code, which is 079.82. So if you're billing the 0301AD for a brief conversation with a patient about their hypertension, you would use both the code for hypertension and the 079.82 COVID diagnostic for that. I'm just going to have a look here. If you are called for sedation in the ER, the best way to claim is to claim for the anesthetic rate to provide that sedation. So you would claim the and not a consultation. So the consultation requirement isn't really being met in that case, but you can appropriately claim for the anesthetic rate for a particular procedure. And Dr. Pretorius, if you have specific questions that you'd like to talk about, please feel free to drop me a quick email or give me a call through the AME's office. For periodic health examinations, the question is, 304A for that. Say yes, as long as you're meeting other requirements for 0304A. So you're having a complete head-to-toe examination of all body systems. You're taking a very comprehensive history of that patient. And then the new requirement that you are developing a care plan and discussing that with the patient, documenting it in the record also has to be met. Sure, keeping in mind all of those requirements and determining, am I going to bill 0304A for this patient contact? And I agree with Dr. Sevier that you need to have decent quality examination of the advice and the plan. That doesn't mean that you have to have a very extensive plan in the same way that the comprehensive care plan that deleted is there. You just need to make
Norma, you keep cutting out.
Comprehensive care plan. Oh dear, okay.
Sorry.
I'm just going to switch speaker.
Okay, so my audio will be starting to fail me. Is this better, Mary Lee?
That is much clearer. I was thinking it was a bandwidth issue, but I thought I better mention it. So we'll see how it goes now.
Okay, they could be just getting tired. So when you're going to bill your 0304A, just make sure that you have some element of a care plan. So that could be talking with the patient about maintaining their current exercise and healthy eating habits. It could be talking to them about making sure they're monitoring alcohol intake, making sure that they're managing their stress levels at work, and so on. So it doesn't have to be that extensive comprehensive care plan, but it does need to make sure, you need to make sure that you have that documented in their file. There's been a question about diagnoses to claim the new virtual care psychiatric code. As long as your diagnosis of that patient having a mental health issue has occurred at a previous contact, it doesn't matter when that contact is, then you can bill for your mental health service. If you are having a virtual visit today with a patient, you make that mental health diagnosis today. Tomorrow you could have another call with them and then start billing your mental health services, the time-based 0819 CW. I'm just scanning the questions. There are quite a few questions about 0305JA, so I think I'm going to go through this one more time. 0305JA really is intended for your very specific and focused team conference about a particular patient, where each of the attendees at the conference has specific and direct care responsibilities for that patient. So that means that you have your chronic disease manager coming in. They've been working with a patient on managing their diabetes, for example. You might have a social worker coming in. They've been working with the patient about managing their living situation. And then the physician and perhaps the nurse are attending, each to bring the skills of their profession and then with direct responsibilities for managing that patient. That conference has been booked in advance, so that means that in the schedule you will be able to see that Tuesday afternoon at 4 there is a team conference to talk about patient A, and the discussion of that patient's care and care requirements has lasted at least 8 minutes in order to bill that one time-based unit. I'm just scrolling through here. Start and stop times for the day recorded in the first patient encounter of each day and the last one. The challenge that I see there is not every single EMR is as good at pulling out that record and reporting on it as others. So it's really important that you're very confident that if Alberta Health came to you 5 or 6 years from now, that you could easily provide that start and stop time of your workday to them. There are lots of time tracker applications that you can use on your phone. They're pretty easy. Most of them have a start and stop function. So I really recommend that you're doing that. You're keeping a spreadsheet. You have some other record other than your EMR record open and close for your start and stop time. I know that people are having trouble getting Alberta Health to respond to emails. And if you find that your questions are not being answered, so for the question about them not replying for 2 weeks or more, please give us a call. You can contact me at my email address, which is norma.shipley@albertadoctors.org, and we can try to get them to recognize the question and respond to it. I think that they are struggling a bit with remote working as well. And so I'm going to pass back to Mary Lee to ask any final questions. And
So thank you very much, Norma, and I think we can sign off.